Yo juro lealtad a la bandera de los Estados Unidos de América, una república que representa. Yep, that works. Erica, can you see that?
Yeah.
And if I do this, do the slides move?
No.
No. Now do the slides move?
Nope.
No. Good gravy, this is annoying. And that's the way we'll keep them, just like that. Now they move?
Yeah.
No. Good evening, all. So did you guys get the handout, the antivirals? Get that out, please. Let's take a look at the anti-herpes virus medicines first on page 5. These are medicines you will almost certainly dispense often, particularly if you do any family medicine or anything like that. So the group of herpes viruses is a big group. The ones that are most well known within that group include the 2 different types of herpes simplex viruses, herpes simplex 1, virus 1 and 2. 2 tends to be more associated with genital herpes. 1 tends to be more associated with the facial herpes. 1 can cause genital herpes, 2 can cause facial herpes, but it's much more common for 1 to be the virus that causes the sores on the lips and the gums that tends to take up residence in the trigeminal ganglia, and for 2 to have latency in the dorsal root ganglia of the sacral ganglia. And then varicella zoster, of course, causes chickenpox. That takes up residence in the dorsal root ganglia, in the sacral/lumbar region, and can later come out and cause shingles. Shingles typically will be one side. There are cases reported of shingles being both sides, but it's usually, definitely the majority of the time, just one side. Tends to wrap around the body. They tend to be blisters. And if you've ever known anyone who has shingles, they smart. They hurt a lot. There's now a good vaccine for people who are older. Shingrix. If you had the chickenpox vaccine growing up, then your chances of getting shingles are quite low. So the agents are listed on your handout and they're shown here. So kind of the mainstay is acyclovir, pretty old drug nowadays. That comes in both an oral and an intravenous formulation. The oral is used the most. Intravenous is used for people with severe cases that are usually hospitalized. It's not terribly well absorbed, but it is well tolerated. If you use the intravenous form, that can cause, at high doses, can cause some side effects that are listed there. It can cause tremors, it can cause seizures, it can cause delirium. Also, because the drug has poor solubility, it can cause crystals in the kidney and mess up the kidney. It can cause nephritis in the kidney because of the crystals and things like that. Now, valacyclovir is a prodrug of acyclovir. So it is very well absorbed. It's very good bioavailability, unlike acyclovir, and then it gets converted into acyclovir. So valacyclovir is a really good oral drug for herpes in general. Pencyclovir is a topical form of these medications. It's only available topically. It's active against both HSV and varicella zoster virus. And this particular drug comes in a prodrug called famciclovir. And famciclovir is given orally and then is converted into pencyclovir. So that drug is used both against HSV and varicella zoster, as with acyclovir and as with valacyclovir. So herpes viruses carry in their genome their own thymidine kinase. Thymidine kinase is what we call in biochemistry a salvage enzyme. A salvage enzyme. Now, what's a salvage enzyme? When it comes to making nucleotides, nucleotides, energetically speaking, are very expensive to make. So there's two pathways for making nucleotides. There's a so-called de novo pathway. Multi-step pathway, very energy intensive. That makes them just from precursors. Then there is the salvage pathway. The salvage pathway takes previously made nucleotides and converts them now into useful nucleotides that can be used to make DNA and RNA. So which one do you think the cell prefers to use? Salvage, right. If you can get it on sale and you can pay full price, which do you do? Yeah, get it on sale. And that's essentially what the salvage pathway does. It lets you purchase something you really need at a discount price. So the herpes viruses, in order to acquire the nucleotides they need to synthesize viral genomes, they have their own polymerase that they encode. And then they have their own salvage enzyme, the thymidine kinase enzyme. Now, the thymidine kinase enzyme, fortunately, is very different from our thymidine kinase. So we can use drugs that inhibit the viral thymidine kinase that don't touch our endogenous thymidine kinase. Make sense? So this is a target that's unique to these herpes viruses. That's why this enzyme is targeted, because it is so different. And these drugs do not inhibit our endogenous thymidine kinase. But if you inhibit this process, namely, you take the drug gets put into thymidine kinase and it gums it up. So now the virus can't make its nucleotides, so it can't make its viral DNA. So its replication shuts down. That's how these work. And because they address a target that is unique to these viruses, they're well tolerated. So these drugs, very good activity against HSV1 and HSV2. Moderate, but still more than adequate activity against varicella zoster virus, and not so hot activity against cytomegalovirus or Epstein-Barr virus, or definitely no activity against HIV, which uses a different enzyme, uses a reverse transcriptase rather than a DNA polymerase. Generally, these drugs are very well tolerated. They have a few side effects. Now, the one that will cause the most side effects is acyclovir. It is really rare for oral acyclovir to cause side effects. So if someone comes to the clinic, they've got these big, huge blisters on the back of their throat, and it seems pretty clear it's HSV. They get oral acyclovir. They ask you, what's this going to do to me? It's going to make me break out in a cold sweat. Am I going to get a terrible rash? The answer is no. Your chances of side effects with these drugs are really small. Really small. If, however, you get intravenous acyclovir, then the drug at high concentrations can cause acute interstitial nephritis. That's at high concentration. Valacyclovir is very well tolerated. There are very rare reports of TTP. It's not clear that is linked to the drug, but the reports are out there, so I'm giving you the news. So acyclovir, because of its lousy bioavailability, you have to dose it pretty often. Valacyclovir, no. Usually once a day will do it. Valacyclovir is more expensive though. Acyclovir is very cheap. Very, very cheap. In fact, how cheap is it? Well, I'll tell you. $10 days with the therapy of acyclovir is $12. That's not going to break the bank for most people. $12. Valacyclovir, 10 days, is about $20. So even valacyclovir is more expensive, but it's not horribly more expensive. It's not $200 or something like that. Still pretty good. Now, famciclovir is more expensive. Famciclovir, 10 days is $35. So more expensive, but is that horribly more expensive? Well, it's close to 3 times what it is for acyclovir, but it's not, $1,000 or $200 or something like that. So. And then famciclovir, as you said, prodrug of penciclovir and so on and so forth. Cytomegalovirus. Cytomegalovirus is a really important virus if you have people who are immunosuppressed. suppressed. It tends to be pretty ubiquitous. We fight it off very easily. CMV, however, if particularly in transplant patients, can cause a really serious disease. It's life-threatening. So as you see here, 60% of Americans are seropositive by adulthood. A lot of people essentially are exposed to cytomegalovirus. In immunocompetent people, it causes infections that really don't cause any symptoms. But in people with suppressed immune systems, cancer patients, HIV patients, transplant patients, it can cause really devastating infections that are even life-threatening. So if any of you choose to work in oncology, infectious disease, working with, well, really any sort of hospitalist will work usually with HIV patients. You may see this virus rear its ugly spikes, so to speak. So the two drugs of interest are goncyclovir. Goncyclovir has a mechanism of action pretty similar to acyclovir. Once again, you have a kinase. This kinase in cytomegalovirus is called UL97. That's found in cytomegalovirus infected cells. That particular drug inhibits it. And then the prodrug is valganciclovir. Valganciclovir has better bioavailability than goncyclovir. So these drugs can cause dose-specific bone marrow suppression. So what test you're going to give to people on goncyclovir? If you want to know if a patient's bone marrow suppressed, you're going to look at bone marrow makes. Thank you, complete blood count. That's your go-to. And you need to adjust the dose by the renal function of the patient. There are algorithms for that you can just look up, and that'll adjust the dose quite accurately. In fact, a lot of those will come in a lot of the programs that you'll use. You can just put in the patient's renal function and it'll adjust the dose for you. Pretty cool. If those drugs fail, I don't have these up there, but you have two other drugs that you can go to. These drugs have more serious side effects. So there's cidofovir and foscarnet. Those are inhibitors of the viral polymerases. Foscarnet can be very hard on kidneys. And so with cidofovir, you can see it is given with IV saline, and it's given with a drug that was used not so much today, it was used more in the past for gout, called probenecid. That's to help its elimination. So with foscarnet, you can get electrolyte disturbances, and that can lead to some pretty severe consequences. So with foscarnet, you need to watch the renal function closely. Again, these are second line. They're used if the other drugs fail. Any questions on anti-HIV, anti-CMV, anti-VZV? Good, very good. Anti-influenza drugs. When I first started teaching this class, there really wasn't much out there. Now we have more drugs for people with influenza. So the granddaddy of this group is oseltamivir, so-called Tamiflu. This drug is oral. There's now an inhaled agent called zanamivir. And there is an IV medication you have to have at the doctor's office or the hospital called Peramivir. That goes by the trade name Rapivab. Zanamivir is Relenza. Oseltamivir is Tamiflu. These are so-called neuraminidase inhibitors. Neuraminidase inhibitors. So the flu is a enveloped virus. It's segmented and enveloped. It has glycoprotein spikes embedded in its envelope. And those glycoproteins include a hemagglutinin and a neuraminidase. The neuraminidase is extremely important for exiting human cells. So if you inhibit the neuraminidase, the virus cannot produce a productive infection of cells. And as the cell sits there with all these virions in it that it can't release, that essentially, it's like essentially taking somebody who's hidden and searching for them for a longer and longer and longer and longer and longer time. You're eventually going to get caught. So the cell will be caught by a CD8 cell, a T cytotoxic cell that will destroy it and destroy the virions. So because it prevents the production of new viral particles, it will stop the productive infection in its tracks. This is the way all these drugs work. They're neuraminidase inhibitors. The difference between them is the way they're administered and their activity. These drugs work best at the beginning of the flu. If you give them after 3 days, starting at the onset of symptoms, they're not going to work. They're only effective against influenza. They're not effective against other viruses. Because the type of neuraminidase that's found in influenza is specific to it. There are also no substitute for vaccination. I must emphasize that. And as working nurses, you guys will be required to get yearly flu vaccines. And in fact, when you start your rotations, you'll have to have all your vaccines, and one of them is a flu vaccine that you have to get every year. Now, the beauty of that is that you guys will have access to the early flu vaccines, unlike yours truly that has to wait and wait and wait. And WeatherWax gets them, and then no, not ready yet. No, not ready yet. And then finally get them. You guys get to get them early. So kudos to you. Get your flu vaccine. How well are these tolerated? Tamiflu in some people causes a lot of GI distress. Now, in the literature, it says that's uncommon, yet everyone I talked to who's taken Tamiflu said it gave them an upset stomach. So I think what the literature says and what people experience might be two different things. You don't take it for very long, but some people experience headache and fatigue. It's not severe and it's reversible. There are reports of psychiatric effects, people getting confused, people hallucinating and things like that. That's restricted to older people or to people who already have psychiatric conditions. Zanamivir, because it is inhaled, can cause coughing and bronchospasm. So it's contraindicated in people with active asthma. It's inhaled with a dry powder inhaler, a DPI. Peramivir, as it says on your handout, tends to be well tolerated, but nausea has been, diarrhea, has been reported, as has neutropenia, but the neutropenia is transient. There is a newer oral agent called baloxavir. Baloxavir is sold under the trade name Xofluza. This is a different class of anti-influenza drug. It does not inhibit neuraminidase. Instead, it inhibits the influenza-specific nuclease. Baloxavir seems to be better tolerated than oseltamivir, causes less GI upset. Because of that, there is talk that it might end up replacing oseltamivir. Now, some influenza strains are starting to show resistance to oseltamivir. Those strains, however, are still very susceptible to baloxavir. These are also effective both against influenza A and B strains. I'm not going to talk about rimantadine or amantadine. The strains available today are resistant to those drugs. They are not used. Amantadine's been repurposed. It has other uses, but the flu is not one of them. Any questions on those medicines? Yes. Well, that's a good question. Let's look it up. Oseltamivir. You take it for 4 days, and it is $25. Peramivir is $40. And you get 1 dose with that. So it's a bag, comes in a bag. Zanamivir, 1 DPI that has 5 puffs in it, essentially. That is $32. And baloxavir, which is the newest, is $40. And those will probably go down as they get used more. So not horribly expensive. They are newer drugs. More questions about these? No? All right, let's go to another set of antivirals. So for this, go to the front of your handout. These are the most complicated of the antivirals because HIV is always treated with a cocktail. And if you want someone's infection to be stable, then you will need to treat it with drug combinations, always, always. So let's talk about the players in these cocktails. So first, remember, HIV is a retrovirus. That doesn't mean it likes music from the 80s. That means that it's an RNA genome and it makes DNA out of that RNA genome. It makes a DNA copy from an RNA template. It uses the enzyme reverse transcriptase. That's unusual. That means it's a target for drugs to treat HIV infections. It then integrates into the human genome. So there's an integrase that does that. That's a target for drugs too. It produces viral proteins. Those viral proteins require processing through a virally encoded protease. That's a target for drugs as well. Virions bud from the host. They lyse the host cell and they go infect another cell. So the genome of the virus contains genes for something called the group antigen, which has the unfortunate acronym of GAG. And then Paul. Paul is the reverse transcriptase. There are some other proteins involved in managing the infection in the cell, VPR, VIF, VPU, so on and so forth. There's the envelope protein that will form the surface glycoprotein, and then some regulators, NEF, REV, TAT, so on and so forth. And then there is a processed version of the polymerase that creates the integrase. The integrase. So you get binding, fusion, reverse transcription, integration, transcription and translation, basically expressing of viral genes, assembly, and then the budding of the virion from the infected cell. And this is a cartoon essentially of what the virion looks like when assembled. So it's an enveloped virus. Beneath the envelope, you have a so-called matrix protein, and then the capsid itself, and then the RNA is actually bound with the group antigens. The group antigens also constitute the matrix proteins as well. The envelope protein forms the GP41, GP120 that's involved in binding the target. The target is the CD4 protein on the surface of T helper cells in combination with a co-receptor. That co-receptor changes during the course of infection. So here are the stars of the HAART, highly active antiretroviral treatment show. So your backbone of virtually all your HAART cocktails will include reverse transcriptase inhibitors. There's two types of reverse transcriptase inhibitors. There are nucleotide reverse transcriptase inhibitors. They mimic nucleotides. Then there are, they bind to the active site and gum up the active site of reverse transcriptase. Then there are NNRTIs, meaning non-nucleotide reverse transcriptase inhibitors. These bind to other sites on the enzyme and gum it up. Then there are drugs that inhibit viral entry into cells, and these are listed here on the front. These are usually not part of a cocktail. These are usually used if lots of other things have failed. So these tend to be more last resort types of agents. Then you have the integrase inhibitors. Integrase inhibitors have very quickly become the other leg in the backbone of HAART cocktails. Integrases are also the newest of these anti-HIV drugs. Then there are the proteases. Proteases proteases will allow viral maturation so that it can bud from the host cell. Protease inhibitors prevent that maturation, prevent budding. Protease inhibitors used to be mainstay in HAART cocktails, not anymore. They have lots of side effects and lots of drug-drug interactions. They're being used less and less. If you look at the main HAART cocktails, they don't include protease inhibitors anymore. They just have too many side effects. But they are still available. All that clear before we go on to the players? With me so far? If you are, go like this. Yes, okay, good, all right. So here are the nucleoside and nucleotide reverse transcriptase inhibitors. So there's tenofovir, stavudine, which doesn't get used very much because it's quite toxic, zidovudine, which has its uses, but is also one of the more toxic of these drugs, emtricitabine, which is very useful because it also inhibits hepatitis B. So if you have someone who's infected with both, emtricitabine is really, really useful. Lamivudine, abacavir, didanosine, which is really toxic, so it doesn't get used a whole lot, and zalcitabine. Of these, lamivudine, emtricitabine, and tenofovir are the three that are used the most. So if you're out of time studying, study those three for sure. Tenofovir, lamivudine, emtricitabine. They're the ones that are used the most. So these folks bind to reverse transcriptase. Reverse transcriptase goes chugga, chugga, choo, choo. It gets one of these in it and it stops. It's like the train hit a volcano and it can't go any further. That will stop the infection in its tracks. Now, why do you need to use other drugs in the cocktail? Any guesses? You guys look so tired. I look out there. Amazing you guys didn't bring your pillows to class. Except for Clara. Clara's always awake. Yeah, you hide it well. You've been working all day or?
I did a 3-hour NCLEX.
Oh, mercy. Okay, no wonder you're tired. Mutations, guys, mutations. They can adapt to these and become resistant to them by acquiring mutations. That's why if you use just one drug, you get escapers that are now resistant to the drug. If you combine drugs, the tendency to get escapers is much, much lower. That's why you have to combine drugs. Because the reverse transcriptase is very error prone. This is why drug companies have tried, but no one's been able to successfully make an HIV vaccine because of the hyper variability from virus to virus, because of the error-prone nature of the reverse transcriptase. Now, I have a list of some of the different types of side effects on the handout. So I'll just go through these very quickly. Peripheral neuropathy, hand and glove, glove and sock neuropathy is pretty common. Pretty common. Gastrointestinal NBD is nausea, vomiting, diarrhea. That usually goes away once you get used to the drug. Bone marrow suppression is also pretty common. Hypersensitivity, that's not terribly common. Abacavir is the biggest offender here, particularly for people with this particular allele of the HLA-B locus. You might want to skin test people with the drug first, or just give a test dose and see what the case is. So lactic acidosis, hepatic steatosis, pancreatitis, those are all liver things or thereabouts. Now, tenofovir is the worst for nephrotoxicity, but tenofovir comes in two forms. There's a tenofovir eliminate fumarate, a TAF, and there's a tenofovir dioxosylyl fumarate, TDF. TAF is better tolerated than TDF. So tenofovir depends which form of tenofovir. And notice that tenofovir is also effective against hepatitis B. Here are some drug combinations that are commercially available and are used today to treat HIV patients. They combine different reverse transcriptase inhibitors. They combine emtricitabine and tenofovir, Truvada. They combine abacavir and zadavudine, Epicom. They combine abacavir and lamivudine, Combivir, and they combine lamivudine and zadavudine in Trezevir. Those are examples of combos that are used today. On page 3, there's a list of some of the different combinations. These combinations are the ones that are most widely used today. Those combinations right there. So if you want to learn some combinations, learn those. Here are the non-nucleoside reverse transcriptase inhibitors. You must use these with other drugs because the tendency for the virus to make mutant strains that resist these is pretty high. So these are found on page 3 of your handout. There's efavirenz. Efavirenz is important because it could be used during pregnancy. It's safe during pregnancy. Entravirine, ropivirine, nevirapine, and delavirdine. So there are 3 there that are safe during pregnancy. Ropivirine, as you can see, has some issues with neurological toxicity. Nevirapine can really mess with people's livers. Nevirapine also has a lot of drug-drug interactions because it's metabolized by 3A4, cytochrome P450 3A4. And here are some drug combinations that use some of these. Atripla and Complera. You can see they use other reverse transcriptase inhibitors with the non-nucleoside reverse transcriptase inhibitors. So again, these bind to a site other than the active site on the reverse transcriptase, but they're still reverse transcriptase inhibitors. And that writing is really small. Can you read the stuff in the red? All right. Yeah. Haley, can you read that all right? Yes? Okay. So there's the central nervous system effects. The biggest offender here is efavirenz. Rashes, all of these will cause rashes, but nevirapine is the one that causes the worst rash. If you give antihistamines, those can prevent the rashes. Hepatotoxicity is an issue. They can cause some metabolic issues. Lipohypertrophy in some cases because of inhibition of lipid metabolism in the liver. And nevirapine, hypersensitivity to nevirapine has been reported, and it can be pretty bad. So what are they good for? They have broad drug interactions, so they have a fair number of DDIs you need to be aware of. They're very good for so-called treatment naive patients, patients just starting HAART. And they're second line for treatment experienced patients. That's what they're good for. Protease inhibitors start on page 1. Notice the ending of these drugs, na-vir. If you see na-vir, they're an HIV protease inhibitor. These drugs will tend to cause metabolic disorders. They tend to increase your risk of diabetes. They tend to cause weight gain. They tend to cause hyperlipidemia. The one that doesn't is atazanavir, the first one there. And that one, just think Tarzan, because it kind of sounds like Tarzan. Atazanavir. Now, ritonavir. Ritonavir is a drug that we need to talk about a little bit. This drug is not that powerful a protease inhibitor. Instead, it's used for something called boosting. Boosting. Ritonavir is a potent inhibitor of cytochrome P453A4. So when you give it plus another protease inhibitor, concentration of that protease inhibitor goes way up. So it's very effective against the virus. Yeah, you have side effects, but you're taking out a lot of virus. So by boosting the cocktail, you essentially make the cocktail a lot more effective against the virus. So ritonavir essentially gives your cocktail this big kick. And it's used essentially for people with high viral loads you need to bring down. And boosting can be a very effective strategy. Your patient, of course, will pay for it, but you'll get their viral load down, which is usually the thing that's most important. So as I said before, you get these protein precursors. GAG, POL, are made as a big precursor protein that needs to be clipped in order to properly mature the virion so they can bud. Protease inhibitors inhibit that HIV-encoded protease, and they prevent virion maturation. So protease inhibitors increase the risk of strokes and heart attacks. They cause nausea, vomiting, diarrhea. If you take them with food, that can reduce that, but they can still cause upset stomachs. They can be hard on the liver. They cause fat accumulation in the abdomen, the neck, the breast, so on and so forth. And they can precipitate out in the kidney and the ureters. You have to hydrate when you're on these drugs. Have to hydrate. or you'll get crystals of them in the kidney and it'll mess up your kidney. That's why these are being used less and less in HAART cocktails. Here's one particular combination treatment. So this is a boosted treatment. It's called Calitra. It has lopinavir and ritonavir. Notice Navir. These are both protease inhibitors. Ritonavir inhibits cytochrome P453A4, the main enzyme that metabolizes lopinavir. So you give Calitra, you get not lopinavir, you get lopinavir. And lopinavir essentially does its dirty work on the virus and knocks it down. That's an example of a boosted cocktail. Am I going too fast? No. I sent this, I did send this to you, right? Yeah. This is on your handout, so if you're having trouble getting it all down, refer to your handout. Integrase inhibitors, these are on page 1. These prevent the integration of the viral DNA after it reverse transcribes the RNA into DNA into the host genome. Integrase inhibitors bind to the integrase and gum it up. These are probably the best tolerated of the anti-HIV drugs. They're also very effective. For that reason, they have become the mainstay of most HAART cocktails. So the adverse effects tend to be nausea, headache, and some myopathy. Integrase inhibitors can also be boosted using this drug called cabicostat. So there are combinations of integrase inhibitors and cabicostat. So there's this one drug called Stribbled. Stribbled has, and notice these always end in gravir. Gravir. If they end in gravir, they're an HIV integrase inhibitor. So Navir, protease inhibitor. Gravir, integrase inhibitor. And I wish there was a logical ending to the reverse transcriptase inhibitor, but there isn't. You just have to know them. Sorry. Don't shoot the messenger. I don't make the news, I just report it. So there's raltegravir, dolutegravir, and then alvategravir. Genvoya is a combo of altegravir plus cabicostat, so it's boosted. And then emtricitabine and tenofovir alafenamide. Tenofovir alafenamide is the better tolerated version of tenofovir. Cabicostat, again, it's a boosting agent for the integrase inhibitors. Cabicostat is not recommended in pregnant women. Two of these, as you see, are safe during pregnancy. Raltegravir, dolutegravir. If you take these drugs with rifampin, they'll induce the breakdown of rifampin. So they'll prevent rifampin from working. So if you have an HIV patient with tuberculosis, you're putting them on a standard cocktail for tuberculosis, you have to substitute something other than rifampin. And they can increase creatine kinase concentrations. Some people will get muscle ache, some people won't. varies from person to person. But that's something to keep in mind with the blood work of patients. Let's talk now about the entry and fusion inhibitors. Right after we take our break, I lost track of time. I'm sorry. You're supposed to remind me, but everyone's so tired, no one's watching the clock. So let's take 5 minutes and then we'll resume. Yeah, because then I can say copy this.
Yeah.
And you can drop it any time. It's crazy.
Yes, that would be.
You,
I was like,
are you guys still practicing? So are you guys still in formal practice?
Yeah, sort of. Like
Sort of.
on Mondays we have open gyms.
You work out.
Yeah.
Okay.
But I went to know. Like using my arms. Yeah. I just know a lot of the girls that but and then that we are and then yeah, my sister's just I know like schools want to and then take my sister to work and I do that and I was like and I had to do a shower. I was just thinking that like I've never actually it's kind of good. It smells like out there. Kind of. That's what it is.
Really? Anaphylaxis? Really? Or just illness?
For illness for sure, but I don't know. He's trying to own his own. They should be going. They don't like it. They're, if you have to have. Oh, yeah. Same review from our race car driver. He's fine. I remember like the first time ever.
So
So confused. I was paying attention.
where?
I was like,
You were just this classy look in your face. I thought at first that you know.
There's only 309.
We came to class, you didn't look like your best friends. And then I thought, well, next time.
That's
maybe
pretty.
just off or something. And then just kind of stared.
I was taking notes. I was
You're
paying
taking notes,
attention.
you're paying attention.
Yeah.
Okay. Okay.
Oh,
What you might have wrong.
I'll just be honest, sometimes I've been told I don't have the nicest like look on my face. Nothing's wrong. Yeah, nothing's wrong. I'm just yeah, I don't have like a naturally nice like resting face. Like smiling.
Uh,
My mom tells me she's like, who do you become? I cannot.
Take lessons from
I'm good. Thank you. No, exactly. Yeah. Well, I'm sure Michael will help him, so, yeah. he can help, I'm sure Michael too.
All right. Okay, back in the saddle. Very good. Let's talk entry and fusion inhibitors. These will prevent the virus from actually fusing and infecting with and infecting cells. So and fuvirtide or Fusion, which I think is a pretty cool trade name, Fusion, that is available as a sub-Q injection. This is a small molecule. It binds to the surface glycoproteins of the virus and prevents it from being able to engage its target. This particular molecule, when you inject it, can cause some pain, and it can actually kind of cause welts in the skin where you inject it. You can get these little, it says here cysts or nodules. That's a good description of what you get sometimes. There's also increased risk of bacterial infection, in particular pneumonia. Nobody really knows why. Then there is an oral medication, Antivirals. This is taken twice a day. It only works on those strains whose co-receptor is CCR5. Whose co-receptor is CCR5, the cytokine receptor CCR5. Typically, in advanced infection, the virus switches from CCR5 to CXCR4 as the co-receptor. If that's happened, Antivirals can't be used. It only works for those that use the CCR5 as the co-receptor. This will cause diarrhea and muscle pain, liver damage. Tends to be usually on the average pretty well tolerated though. This too is a small molecule that prevents the glycoproteins from binding to targets. So these are typically add-on treatments. If you have a cocktail, these will be added on to prevent further infection of other cells. That's what these are used for. Now, these other two agents on your handout, these are very new agents. So the first one here, number C on letter C on page 1, the abelazumab. Abelazumab is a monoclonal antibody. It is used in people who are heavily infected and for whom certain treatments are not working quite so well. So this will block the CD4 receptor, prevent the virus from binding it, but it doesn't interfere with CD4 function, which is pretty cool. So this can cause some dizziness, diarrhea, nausea, and rash. Diarrhea is probably the most common side effect. This, however, can cause something called immune reconstitution syndrome, which means you're used to having an immune system that works here. Now all of a sudden your immune system starts to work here. And now all this inflammation you should have been having, you now start to have. So that's called immune reconstitution syndrome. So that can cause a patient a world of hurt. That's pretty common with that particular agent. So that's something to be aware of. And then the last agent here is fostemsavir. This is a extended release tablet. It's also a GP120 inhibitor. Prevents it from binding to its targets. You can see it was not approved that long ago. This can also cause severe immune reconstitution syndrome. This drug also prolongs the QT interval. So that is something to be aware of. These other ones, nausea, headache, diarrhea, those tend to be transient. Those usually aren't such a big deal, but they are reported. Please turn to page 3. Take a look at number 6. If any of you work OB, labor delivery, doing women's health, this will be important information for you. Safest combo during pregnancy is that combo dolutegravir and emtricitabine and tenofovir alafenamide fumarate. That's the safest. Second string is this emtricitabine with another tenofovir analog. The other one is you can substitute the emtricitabine with lamivudine. And then fourth string is abacavir with lamivudine. Atazanavir with low dose ritonavir is on the books, but all the OBs I've talked to have said, we don't use that anymore. So that is probably going to come off the lists before long because it's not really being used. 2, protect the baby. Women in labor should receive IV zidovudine. And infants born to such mothers should receive 6 weeks of zidovudine and the 3 doses of nevirapine during the first week of life. That particular treatment does a very good job of preventing the baby from having HIV if you follow that protocol. That is a well worked through protocol that works. Yes. It's it's F on your handout. You have your handout? Yeah. Take a look at page 3 and look at F. You see it? Where it says for treatment during pregnancy, see that?
Oh, yes.
Page 3, they go A, B, C, D, E, F, right at the bottom F,
Yep, got it.
right there.
Thank you.
And what about treating hepatitis C? So I have some drugs here for hepatitis B. Hepatitis B tends to be treated with interferon. On page 4. Interferon tends to give people a whopping fever. The biggest thing you need to watch with interferon. A lot of people who get on interferon, they don't stay with it because it makes you feel just miserable. Biggest thing is the fever. You have to really watch the fever. If the fever gets too high, your patient's going to be in a world of hurt. Now, hepatitis C for years were treated with ribavirin and interferon. This would suppress the virus, it wouldn't cure the virus. So this causes a chronic liver disease. It's blood-borne. A lot of people globally probably have it. This will just chip away at your liver little by little until all of a sudden you go get a checkup and they say, your liver's failing. You say, well, because of this insidious infection that just keeps pounding away at your liver. Globally, some 400,000 people a year die because of hepatitis C complications or because of hepatocellular carcinoma due to chronic hepatitis V infections. Now there are drugs that can cure the virus and don't include interferon. These are also present as combination treatments. So the genome of hepatitis C, it's an RNA virus. You make this big polyprotein, not unlike what you see in polio or Coxsackie virus or any of that other coronavirus group. And then you clip it into the viral polypeptides. And some of these polypeptides are RNA replicases or proteins that aid the RNA replicase, and some of them are viral proteases. Fortunately, those proteases are unusual, and those viral replicases are unusual. So drug companies have made some excellent small molecules that inhibit these proteases and replicases. And when you give them in combinations, they completely rid the body of hepatitis C virus. Something that you almost never could say with interferon and ribavirin. So the protease inhibitors, take a look at the ending. What ending do you see in these drugs? Previr. If you see Previr, it is an anti-hepatitis C protease inhibitor. Previr. Boceprevir, telaprevir, cimeprevir, piratemprevir, rizoprevir, glecaprevir, voxilaprevir, so on and so forth. No, the combos are on page 5. Then there are the so-called NS5A inhibitors. NS5A. NS5A is a, oh, replicase, let me help you protein. Fortunately, it's a protein whose structure is well solved. Fortunately, the docking site between it and the replicase is well understood. And fortunately, you can make small molecules that will prevent it from docking with the RNA replicase. These are called the NS5A inhibitors. Take a look at the ending of these drugs. What do you see? Right, AS-VIR, AS-VIR. So if we say AS-VIR, it is a NS5A inhibitor. And then you have the actual replicase inhibitors. So these will take the viral template RNA and use it to make the negative strand that is then used to make the plus strand that gets packaged into the genome. These take an RNA template to make an RNA molecule. Do our cells have things like that? Now, so this is a novel target. So Fosbuvir and Desabuvir. You see the ending there? Buvir. So if you see Buvir, it is a hepatitis C RNA replicase inhibitor. Now, here's the kicker. There's different genotypes of hepatitis C. There are variations in their genomes, and there are 7 different recognized genomes: 1A, 1B, 2, 3, 4, 5, 6. And it turns out these drugs specialize in inhibiting different genomes of hepatitis C. So you take someone's hepatitis C, you sequence it, you find out its genotype, you know what drugs you're going to give to them. Just like that. So if you look at page 5, there is a combo called Harvoni. Harvoni has lenacapavir and sofosbuvir. Sofosbuvir is which kind of drug? Replicase inhibitor. Lenacapavir, what kind of drug is that? (5A) inhibitor. That combo works for all genotypes of hepatitis C, all 7 of them. 12 weeks of that, you don't have any more hepatitis C. Vicura, which comes as a pack, so it's Vicura pack. That has these 4 drugs. That is specialty medicine for genotypes 1A and 1B. Tecnivi has those 3 drugs. It specializes in genotype 4. And then Sovadac has those 2 drugs, Declastivir and sofosbuvir. That works for all genotypes. And now we have this drug called Maviret. If you look at C at the top of page 5, Maviret has this Verbentasvir, and it combines it with the glicapavir. Maviret works for excuse me, all genotypes of hepatitis C, all of them. And then there's this other drug called Zapatier that contains elbasovir and grazoprevir, and that works for genotype 1. By 1, it's 1A or 1B, either one, and genotype 4. Those are the combination medications for hepatitis C. These particular drug combinations, on the average, are very well tolerated. Some people get tired on them. Some people have upset stomach, that tends to go away. Some people get headaches. These are infrequent. These drugs are quite well tolerated. So Maviret, the most commonly reported adverse effects were headache, fatigue, and nausea. And if you're co-infected with hepatitis B, you can reactivate hepatitis B, so you don't use it in people who are co-infected with hepatitis B. That side effect profile is pretty common for each of the anti-hepatitis C. Any questions about any of the antivirals? Very good. And now for something totally different. Let's talk about diabetes, shall we? We shall. So the two main types of diabetes, type 1, type 2. They used to be called insulin dependent and non-insulin dependent. They're not called that anymore because a lot of type 2 diabetics take insulin. So they're called type 1, type 2. Type 1 results from destruction of the beta cells. So the patient no longer makes sufficient amounts of insulin for their metabolism to work. This is significant because insulin is the most important anabolic hormone in your body. Without insulin, you are dead meat. That's type 1 diabetes. Type 1 diabetes is usually in 99.2% of the cases the result of an autoimmune attack on the beta cells that destroys the beta cells. Type 2 diabetes is a result of insulin resistance. Insulin resistance. Normal levels of insulin do not get the cells to respond as they should. Your cells are resistant to insulin. That's type 2 diabetes. Type 1, onset tends to be acute. Type 2 tends to be gradual. Then in the elderly, sometimes there's often asymptomatic diabetes that may be the result either of a combination of obesity and very tired beta cells, or it may be asymptomatic in a lot of elderly people. So without insulin, cells do not get the signal to take up glucose and use it. So your blood is awash in glucose. You have all this energy out there your cells can use, and they don't have access to it. So your cells are starving, even though they're drowning in potential energy sources. Type 2 diabetes also runs in families. There are so-called genome-wide association studies that have mapped over 100 genes that play a role in the onset of type 2 diabetes. So type 2 diabetes does have a genetic component to it, but it is very commonly linked with obesity because adipocytes release cocktails of signaling molecules called adipokines. Many of these adipokines are very important for insulin sensitivity. As the fat cells increase in size and in number, their adipokine profile changes. And they now start to make adipokines that cause insulin resistance. That's the Reader's Digest version. It's a lot more complicated than that, but let's just keep it simple for tonight, shall we? The main symptoms of diabetes are the three P's: polyphagia, polydipsia, polyuria. Polyphagia, always hungry, always eating. Polydipsia, always thirsty, always drinking. Polyuria, with all that drinking, the water's got to go somewhere. Fatigue, dry skin, blurred vision are also signs, but those big three, the big three Ps, polydipsia, polyuria, polyphagia, those are definitely the big three. Long-term complications of diabetes are manifold, but the places where they are most acutely seen are primarily in the vasculature. Diabetes causes the vessels, blood vessels, to thicken, but paradoxically to also become leaky. So they thicken, but they don't work very well. That's going to tend to cause a lot of swelling, lots of mini edemas all over the place in your body. So diabetic vascularitis, that's one of the first profound complications of diabetes. Secondly, diabetes affects the glomerular Bowman's capsule boundary. And the high sugar derivatizes proteins in that boundary. And pretty soon that boundary gets broken down and it causes a type of diabetic nephrotic syndrome. If you don't remember nephrotic syndromes, please go back to your pathophys book and review nephrotic syndromes. Third, diabetic cardiomyopathy. Your heart has to be fed with blood vessels, but those blood vessels are falling apart. Your heart, therefore, is going to go several rounds with Joe Louis, and it's not going to win. Fourthly, diabetic neuropathy. First place you feel this is in the feet. It can spread to other organs, but you'll see it in the feet first. The Bible quiz team at West Branch, my good friend, the Durfees, lead the Bible quiz team there. Mike Durfee, I love that guy, but he does not take care of himself. He's a severe diabetic, and his diet is terrible, doesn't exercise, and he won't listen to anybody. Not even his lovely wife, Terry, who's one of the nicest people you'll ever meet. Mike, last time I met him, he had no feeling in his toes. Now he has no feeling up below his knees. It's getting worse. He might need to have his legs amputated at some point. And I'm going to cry the day that happens, but that's what he's looking at. He doesn't take care of himself. Finally, diabetic retinopathy. With the beating that the blood vessels in the retina take, the retina now will start to have its blood vessels move outward to try to find more nutrients. Those vessels are going to displace photoreceptors, and that is going to diminish your vision. The mainstay test for diabetes is an oral glucose tolerance test. You guys did this test in lab, I think, didn't you? You drink that really disgusting sweet stuff? No? Here's how you do it. You make this stuff, they call it glucola. It's disgusting. It's 25% glucose. Really sickly sweet. Anyway, when I do this lab, I always put a bunch of lemon juice in, so it tastes more like lemonade. You drink 4 mils for every kilogram body weight of glucola. And before you do that, you get a baseline fasting glucose. You have to fast 12 hours for this test. You have the test, and then every half hour, you get your blood glucose taken. And so your blood glucose usually will go up, and then it should go down. A diabetic, it'll tend to go up and up and up, and then come down very slowly. So if you have a fasting plasma glucose above 126, that's an automatic diagnosis of diabetes mellitus.
Is that the same kind of test that they do for gestational diabetes?
With that, it's an 8-hour fast. And you don't drink quite as much glucola. So it's a modified test, but yeah, it's similar. If you reach over 200 mg per deciliter in an oral glucose tolerance test, that's an automatic diagnosis for diabetes mellitus. And if you have the symptoms of diabetes, plus you get close to 200, that will also be worth a diagnosis of diabetes mellitus as well. So normal fasting glucose should be in the vicinity of 100 mg per deciliter. Usually, your doctor will give you up to about 104. Above 104, you're pre-diabetic. If you get above 126, fasting glucose, you're deemed a diabetic. All right, we are out of time, so we'll continue this on Wednesday. So for Wednesday's quiz, it's over the antibiotics, the antifungals, and the antivirals. Write your questions on those. All right? Okay, gang. Hope you guys all feel better. Have a good evening.
Thank you.
And yeah, have a good evening and all that. Ciao.
You too.